इसमें let's talk about first testes. Now, how many testes are there? Usually two. Usually two. And good thing about testes is that there are two testes, but we have to read only one. So, कितना relief है ना? So let's now talk about testes. First of all, let us talk about the descent of testes. In descent of testes, there are two important factors for descent of testes. One is the mechanical factor. Another is the hormonal factor. Mechanical factor and hormonal factor. Out of hormonal and mechanical factor, most important factor is hormonal, right? And obviously in hormonal it is androgen. In mechanical factor, important point to notice, the most important mechanical factor for descent of testes is gubernaculum. The other factors which are responsible for descent of testes are intra-abdominal pressure and also genitofemoral nerve. Important point to note is that genitofemoral nerve also helps in descent of testes. It guides the testes to the inguinal canal. Important. Now, failure of descent of testes is called undescended testes or crypt orchid testes. Failure of descent of testes is called undescended testes or crypt orchid testes. The most important predisposing factor for undescended testes, very commonly question asked, is birth weight. If there is a low birth weight or if there is a prematurity, there are very high chances of having a undescended testes. Now, what we are going to do now, we will just write down the theoretical things and then we'll put them in a clinical perspective. Okay. Most common location of undescended testes is intracanalicular. Intracanalicular, that is inside the inguinal canal. Most common presentation of undescended testes is absent testes. Investigation of choice for undescended testes as per the latest is laparoscopy. And the most common anomaly associated with undescended testes is inguinal hernia. Important. Patients who have undescended testes, they also have inguinal hernia in them. Then the most common complication associated with undescended testis is atrophy of the testis, leading to infertility. Most common complication of undescended testis is atrophy, leading to infertility, followed by carcinoma. Most common carcinoma it leads to is seminoma testis. Most common carcinoma it leads to is seminoma testis. Important. Then the treatment of choice for undescended testis is orchiopexy. And the best time of doing this orchiopexy is between 6 to 12 months. If 6 and 12 months both there in your choice, better to take 6 months as the answer. A two-stage orchiopexy. There is an orchiopexy called two-stage orchiopexy. A two-stage orchiopexy is called Stephen-Fowler's orchiopexy. Stephen-Fowler's orchiopexy is a two-stage orchiopexy. Okay, now you have written the theoretical things at this moment. Now let's put them in a clinical perspective and understand that how are we going to go about in a clinical question if the question comes in exam. First of all, in undescended testis, there is a failure of descent of testis through its normal path. Okay, so how do these patients are going to come to us? They will come to us with absent testes. Hello. मैं आपसे बाद में बात करूं, मैं फेस पे हूं. Absent testes. Now, obviously, the parents of this newborn will bring this newborn to you with a complaint of absent testes, right? Now, what will be your next step? Obviously, you do the clinical examination. Now, in clinical examination, this is a very important point. In clinical examination of a patient of undescended testis, the scrotum, where the testis is absent, that side of the hemiscrotum will be poorly developed. Means the rugosity, normally the scrotum has rugosities. This side of the scrotum, which has a absent testis, that scrotum will not have those rugosities. So that hemiscrotum will be poorly developed. So if you get in a clinical question this information, you should think of a undescended testis, because there can be another problem also where there can be absent testis, but scrotum can be well developed. What that condition is, we'll be talking about. So if you get this, you should think of a undescended testis first of all. Now, in such newborns, on clinical examination, it is quite likely, please understand this, most common location of this is intracanalicula. Most common location of this is intracanalular, means at the inguinal canal. So it is quite possible that you can feel the testis in the inguinal canal, because if it is in the inguinal canal, you will be able to feel it, right? It is also quite possible that the testis is not in the inguinal canal, it is higher up in the abdomen. So if it is inside the abdomen, you will not be able to feel it. Now, in either of the situation, to this patient, we will advise re-examination after 6 months. We are not going to do anything at birth. We will wait for 6 months. Why so? Because up to 5th month, maximum chances are there up to 5th month. We should know that if the testis has to descend, it will descend in coming 5 months. If it is not descended in 5 months, it will not descend ever. So we should wait for 6 months, 1 month extra. Now, on re-examination, very important discussion it is. On re-examination, this time, again, the testis is not palpable. Testis not palpable means not palpable at all, neither in the inguinal canal, nowhere else also. So it is not palpable. It is also possible that the testis is felt in the inguinal canal. Right? So if you can feel the testis in inguinal canal in a patient whom you examine at 6 months, you should advise inguinal orchiopexy. Means you will, what is orchiopexy? You will give an incision on the inguinal canal. You will take out the testis and pull it down and put it in the scrotum. So when you put the testis in its normal anatomical position and fix it there, it is called pexy. So we will do orchiopexy. Okay, we have fixed the testis to the scrotum once we find a testis in the inguinal canal. Okay, you could not feel a testis at all. It is not palpable. What we will do? We will take the patient to the operating room and do a under general anesthesia examination. We will re-evaluate under general anesthesia. If on re-evaluation, the testis is still not palpable, and it is also quite possible that it is palpable in the inguinal canal. Because what happens is, when you put a hand in the inguinal canal in a 6-month-old baby, they may not allow you to do the proper examination. So if they start crying, they are resisting your examination, so you will not be able to palpate it easily. So you may palpate, you may not be able to palpate. So you should do an under G examination. If on under G examination, this time the test is in the inguinal canal, we have to open inguinal canal and do a orthopexy again. Right? But if the testis is still not palpable, we will do a laparoscopy. In laparoscopy, we will try to search for this testis. Now, if the testis is there higher up in the inguinal, not in the inguinal canal, it is higher up. In this patient, we will do a two-staged. We will not do a inguinal orchiopexy. It will be a two-stage orchiopexy. That is, we can't bring this testis down to the scrotum without tension. Testis is higher up. The testicular vessel will be small, short. So when you try to bring it to the scrotum, it will be under tension. So we don't want a tension ever. So for bringing the testis down to the scrotum without tension, we have to do this procedure in 2 stages. When we do procedure in 2 stages, it is called Stephen Fowler's orchiopexy. Right? Now, if the testis is now in the inguinal canal, found to go in the inguinal canal, you are doing a laparoscopy, and under G also you could not palpate, but on laparoscopy, you could see that it is in the inguinal canal. you will again do inguinal orthopexy. Now, it is also quite possible that you will find that the testicular vessels are ending blindly. Testicular vessels are ending blindly. If you find a testicular vessels ending blindly, you will conclude that the testis is absent. You will conclude that the testis in this given patient is absent. So this is a very important clinical approach. Now you know the theoretical thing also in the subject. You know clinical thing also in this in this subject. You have seen that in every condition. I made you try to make you understand the clinical part also, right? So clinical part is what we have to be geared up for this exam, right? So and why we are so eager to do it at 6 months. What is the reason of doing this orthopexy at 6 months? 6 to 12 months is a time. But why are we so aggressive in doing? I told you 6 and 12 months both there is a better 6 months as an answer. Why so? No? Because there is a reason of testis being in scrotum. We know that. The temperature difference. More the testis spend time in a higher temperature environment situation, the testis start having a degeneration. And the testicular function keeps getting lost. So we don't want that to happen. So we bring it down to the scrotum as early as possible, and that time is 6 months. The second reason for bringing it down is that the testis, which is higher up in the inguinal canal or in abdomen, has a risk of malignancy also. So this is what is the reason why we are doing it at 6 months. Then comes, there is something called ectopic testis. Not required, just name required. Sirf naam hi kafi. So ectopic testis. What is ectopic testis? When a What? If the football can cricket ball, okay, cricket ball hits the testis. Why does it change position? Why would it change position, by the way? हाँ? फ्रेंड का हो गया है, पक्का फ्रेंड का ही है ना? पहली बात तो सुनो, ये जो टेस्टिस पे जब बॉल लगी, क्रिकेट बॉल, तो वो क्या अनडिसेंटेड टेस्टिस पे लगी थी कि नॉर्मल टेस्टिस पे लगी थी? नॉर्मल टेस्टिस पे बॉल लगने के बाद टेस्टिस गायब हो गई, ऊपर चली गई, ऊपर चली गई, नहीं, कहां चली गई? Where did it go? देखो सुनो, one of the reason which you are telling me, कहाँ से आया यार ये? उसका ऊपर चढ़ जाता है, पोजीशन चेंज कर लेता है। उसका रीजन ये होता है कि when the trauma happens, there is a bleeding and inflammation happens, and when inflammation happens, the fibrosis happens. Because of the fibrosis, the cord can pull the testis up, but up मतलब कि थोड़ा up, ये मुंह में नहीं आता। कहाँ चली गई? अभी क्लास के बाद डिस्कस करेंगे कहाँ गई, अभी क्लास कर लेते हैं। Ectopic testis. Ectopic testis. Ectopic testis is, in ectopic testis, testis descends through a normal path of descent, but after its exit from superficial ring, it gets misdirected. Testis here in this condition is descending through a normal path of descent only, but after its exit from a superficial ring, it gets misdirected. Where all it can get misdirected to? The most common site of ectopic testis is superficial inguinal pouch, which is also called Dennis Brown pouch. Superficial inguinal pouch or a Dennis Brown pouch. One can find testis at the root of penis. One can find testis in opposite scrotum. One can find this ectopic testis in perineal region. Can also find it in femoral triangle. Now, how will these patients going to present? They will again present to us with absent testis. But on examination of these patients, you will find the hemiscrotum where the testis is absent. That side of the hemiscrotum you will find is well developed. That side of the hemiscrotum you will find is well developed. So this is a very important clinical clue to differentiate ectopic testis from a undescended. Now, one more important thing. There is a condition, please be very careful about these in clinical scenario questions, called retractile testis. What is retractile testis? Retractile testis is one, in some of the patients, the cremastic muscles are hyperactive. Because of a hyperactive cremastic muscles, because of the spasm of these muscles, the testis may be higher up in the inguinal canal. Testis, when the muscles are relaxed, the testis will come down, but when the muscle contract, the testis goes up in the inguinal canal. This kind of testis, which is after the spasm of the muscle going into the inguinal canal is called a retractile testis. And in a retractile testis also, the hemiscrotum you will find will be normal. How will we differentiate a retractile testis from an undescended testis and from ectopic testis? Please, these are important clinical things. Hemiscrotum, if is poorly developed and you don't find a testis in the scrotum, it is an undescended testis. If the hemiscrotum is well developed and the testis is not found in the scrotum, but it is found in any of these locations, means instead of being in the inguinal canal, the testis is superficial to the inguinal canal, in the pouch, it is an ectopic testis. If it is in the inguinal canal, but yet the testis, the scrotum is well developed, it's a retractile testis. Have you understood? The first investigation in these patients of ectopic testis, retractile मतलब कि testis सब muscles के spasm के कारण ऊपर है, retract कर लिया. हेमिस्क्रोटम अगर डेवलप्ड है तो या तो ये एक्टोपिक हो सकती है या फिर रिट्रैक्टाइल हो सकती है. अगर टेस्टिस सुपरफिशियल इंग्वानल कैनाल के ऊपर है, सबक्यूटेनियस प्लेन में है, तो इसका मतलब ये एक्टोपिक है. अगर इंग्वानल कैनाल के अंदर है, सबक्यूटेनियस प्लेन में नहीं, इंग्वानल कैनाल के अंदर आप फील कर रहे हो, तो इट इज अनडिसेंडेड. फर्स्ट इन्वेस्टिगेशन इज अल्ट्रासाउंड. इन्वेस्टिगेशन ऑफ चॉइस इज MRI, and the treatment of choice here also is orchiopexy. And the most common complication of ectopic testis important is trauma. Trauma to the testis, not to the patient. Mind it. Trauma. Hello. Trauma. What are you searching? And can you tell me, and one more very important thing, in ectopic testis there is no risk of malignancy. It is in undescended testis where we have a risk of malignancy in future, right? So these are the things we need to know in a ectopic and undescended testis. Then comes normal है, कुछ नहीं करता. Then comes it comes, but if the muscles are relaxed, if the patient, say for example, patient is sleeping, the testis, because that time our muscles are relaxed, so you may have the testis in the scrotum. But in those patients where there is a hyperactive premestic muscles, so they are in spasm, so it may be higher. Then comes testicular torsion. Now, in testicular torsion, what is testicular torsion? Torsion means when the testis rotates on its vascular pedicle. When the testis rotates on its vascular pedicle, leading to compromise in the blood supply, of the testis, is called torsion. And the most common cause of testicular torsion, important, the most common cause of testicular torsion is high investment of tunica, which is also called bell clapper deformity. What is this bell clapper deformity? देखो normally क्या होता है, ये testis है और this is the epididymis like this, snugly applied to it, and then there is a spermatic cord, right? And this is covered by tunica LBG. ठीक है? In some of the patients who have a bell clapper deformity, उनमें क्या हो जाता है? They have this kind of the epididymis lying like this. There is epididymis like this. It is so like a bell clapper, means you can see that the testis is hanging like a bell, so it can rotate anytime, right? So this is called bell clapper deformity, right? Now this is the reason of a testicular torsion most of the time. But then just by having this kind of a testis doesn't mean that it is going to rotate. There are going to be a predisposing factor for testicular torsion. First of all, most common age of presentation of these individuals is this common in a young individuals. And the predisposing factor for this torsion is, the predisposing factors for this are sudden, trimesteric, muscle spasm, or cold temperature. This commonly happens in winters. Commonly happens during winter season because of the cold temperature, because of the muscular contractions, right? So there will be a classical presentation of a patient of a testicular torsion. Sperm formation? Sperm का इससे कोई लेना देना नहीं. Now you will be provided the clinical profile of the patient is going to be the key here. You will be told the patient age provided for testicular torsion to think in that direction will be young individual, and you will be told that while doing some kind of a muscular effort, he suddenly started complaining of a severe pain in scrotum. So the most common presentation of these patients is severe scrotal pain. They can have vomiting also. Fever is usually absent, but in a later stage, fever can come. Initial stages, fever will not be there. On examination of these patients, you will find there is a severe tenderness. This pain is sudden severe scrotal pain. Severe tenderness is there, and you will find the lie of the testis. Lie of the testis is horizontal. Lie of the testis has changed. You will find a shortened spermatic cord, and you will find that the trimesteric reflex of the patient is absent. Now, please be very careful. Testicular torsion, the most important differential diagnosis of testicular torsion is epididymo-orchitis. The most important differential diagnosis of testicular torsion is epididymo-orchitis. Inflammation of epididymis and testis is epididymo-orchitis. Now, how on the basis of a clinical profile we are going to make out that we have to go and think in direction of epididymo-orchitis? or testicular torsion. In case of epididymoorchitis, first of all, the pain will have a gradual onset. There will be gradual onset. Inflammation of testis and scrotum is epididymoorchitis. And epididymoorchitis and testicular torsion, we need to differentiate clinically. So to differentiate testicular torsion from epididymoorchitis, these are the points which will help you. If there is a gradual onset pain in scrotum, which is not severe, it may not be severe pain, right? Patient here also can have vomiting. Fever in this is usually present. Fever here will be usually present. And if the examiner is generous enough and is happy with you, which is most of the time not, he will provide you that there is increased frequency of micturition also. Not severe. Gradual onset pain which is not severe. Sorry. Increased frequency of micturition. Why there is increased frequency of micturition? Because the most common reason of testis and epididymis to get inflamed and get infected is the source is from the urethra. The infection, urinary tract infection, goes retrogradely to the testis and makes it inflamed. So increased frequency of micturition, if provided, it's a very important clue. Then there will be tenderness here also. In this, lie of the testis will not be changed. In this, the cord, instead of being shortened, here the cord will be thickened. The cord here will be thickened. Here, the cremastic reflex will be present. Okay, now a very important test. Okay. ठीक है ऐसा कर सकते हैं ठीक है चल देखते हैं कल आके कल आके प्रोसेस करते हैं It's a very important test to differentiate epididymoorchitis from testicular torsion. Now, this is called Prehan's test for sign. Now, on elevation of the testis, in case of testicular torsion, the pain gets aggravated. On elevation of the testis, in testicular torsion, the pain is going to get aggravated. While in case of epidermolysis, pain on elevation of the testis gets relieved. Pain on elevation of the testis is going to get relieved in a epidermolysis. So if these things are there, you can make out whether you are dealing with torsion or epidermolysis. Now, please listen to this point very carefully. And this is what they check also. Moment you have a clear-cut evidence of moment you have a clear-cut evidence of testicular torsion on the basis of your clinical signs and symptoms, every single minute delayed will cost testis. So we will, without wasting any time, explore scrotum. And we will immediately explore, and if the testis is found gangrenous, please, this is important. If the testis is found gangrenous, we will have no choice but to do orchidectomy. We have no choice but to do orchidectomy. But we will fix the opposite testis to the scrotal wall still, which is called orchiopexy of the opposite testis, because once a patient has developed a testicular torsion of one testis, there are very high possibility that the opposite side testis also have the chances of a torsion in coming time. So we should fix the opposite testis in the same sitting, which is called orchiopexy of the opposite testis. But if the testis is not found gangrenous, we will derotate the testis. We will derotate the testis and do bilateral orchiopexy. Means we will fix both the testis. So that means in a surgery for testicular torsion, we have to fix the opposite testis to the scrotal wall in the same sitting. Okay, but if the diagnostic clinical signs are not clear cut, if the profile of the patient is such that you are not able to differentiate clearly whether we are dealing with epidermolysis or testicular torsion, we have to do color Doppler. So the investigation of choice for testicular torsion is color Doppler though, but you should understand that color Doppler you are not going to do once your diagnosis of testicular torsion is clear cut on the basis of patient's clinical signs and symptoms. If there is doubt, then only you'll do a color Doppler. And if color Doppler says that it is torsion, you will explore. If the color Doppler says it is epidermolysis, you will advise patient antibiotics, anti-inflammatory drugs, and you will tell the patient to wear tight undergarments for scrotal support. Understood? This clinical understanding is very important here. Any confusion है तो please let me know. अगर आपका डायग्नोसिस क्लियर कट है, क्वेश्चन की प्रोफाइल ऐसे है कि आपको क्लियर कट सडन सीवियर पेन पेशेंट को शुरू हुआ आफ्टर सम मस्कुलर एफर्ट, प्रेहान टेस्ट में ऑन एलिवेशन ऑफ टेस्टिस देयर इज अ पेन aggravating, so it is clear cut that it is torsion. You will not waste time, you will explore. But if the profile provided in a given question is not clear cut, you are not able to कुछ signs आपको torsion के बताए हुए हैं, कुछ epidermolysis के बताए हुए हैं, तो you are doubtful. So you will first do color Doppler and then decide. Understood? And the direction of rotation of the testis in testicular torsion. Open book, close book. It is in torsion, it is open. The book opens up, means the right testis rotates anti-clockwise, left testis rotates clockwise. Open book. And you have to close this book to derotate. So, open book is right testis clockwise, left testis anti-clockwise. So, the direction of rotation of testis in testicular torsion, right testis anti-clockwise, right testis clockwise, left testis anti-clockwise. Right? This is about the scrotal support. Then comes carcinoma testis. The carcinoma testis, very important, is a most common malignancy. Between of testis. It's a most common malignancy in males, obviously, between 20 to 40 years of age. And the most common testicular tumor, very commonly asked question, is seminoma. Most common testicular tumor is seminoma. Please be careful. If you are asked most common testicular tumor in a pre-pubertal age group, it is teratoma. But please be careful. If you are asked what is the most common malignant testicular tumor in a pre-pubertal age group, it is yolk sac tumor. It is yolk sac tumor. And if you are asked what is the most common testicular tumor in elderlies, it is lymphoma. DL, BL. Diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma. Right? The tumor marker, diffuse large B-cell lymphoma. Tumor marker for testicular malignancy are alpha fetoprotein, important, beta HCG, alpha fetoprotein, beta HCG, LDH, not MDH, LDH, placental, alkaline phosphatase, alpha fetoprotein, beta HCG, LDH, placental, alkaline phosphatase, gamma glutamyl transpeptidase, placental, alkaline phosphatase, gamma glutamyl transpeptidase, alpha fetoprotein, beta HCG, LDH. And very important to know, alpha fetoprotein is not raised in, very important, alpha fetoprotein is not raised in seminoma and choriocarcinoma. Alpha fetoprotein is not raised in seminoma and choriocarcinoma, right? And most common mode of spread of testicular malignancy is lymphatic. And very, very important to note, the lymph nodes which are involved, very important point, the lymph nodes which are involved in testicular malignancy are para-aortic or inter-aortocaval lymph nodes. Important. That is retroperitoneal lymph nodes. Para-aortic or inter-aortocaval lymph nodes. Okay. Inter-aortocaval. Testicular malignancy can also spread by a blood-borne route. When it spreads by a blood-borne route, the most common site of distant metastasis is lung. Most common site of distant metastasis is lung. Most common site of distant metastasis is lung, and in lung, here also there will be a cannonball metastasis. Here also there will be a cannonball metastasis. Now, most common presentation of testicular malignancy is painless testicular mass. Painless testicular mass. Patient can also present to us with abdominal mass. Can anyone tell me what could be the reason of abdominal mass? Very good. Undescended testis developing into malignancy, or the retroperitoneal lymph node enlargement, right? So patient can come to us with abdominal mass. Patient can also come to us with a testicular mass. Patient can have a left supraclavicular lymph node enlargement also. Patient can have a left supraclavicular lymph node enlargement also. Investigation of choice for staging is CT scan. Transscrotal biopsy is absolutely contraindicated. Transscrotal biopsy is absolutely contraindicated. Okay, and in management of a testicular malignancy, we have the option of chemotherapy, we have the option of radiotherapy. Preferred is chemotherapy. Platinum based chemotherapy, that is cisplatin और कार्बोप्लाटिन. अब ये जो हमने लिखा है पूरा लिख लेते हैं पहले. Most important prognostic factor is prognostic factor. It is histology. 2 malignancies. And the worst prognosis is of choriocarcinoma. And one thing more you should know about choriocarcinoma, it mainly spreads by blood-borne route. It mainly spreads by a blood-borne route. So these things you have written, theoretical things, and you have written it at a spinal level without understanding what you are writing. And you'll just mug it up. And this is not going to help you in the type of questions you are getting these days. So let's understand that how the things are going to go well. So before I proceed to that, most important risk factor for testicular malignancy is cryptorchism. Now let's talk about the clinical approach. Most important risk factor is cryptorchism. What is the most common malignancy developing in cryptorchid testis? Seminoma. Abhi to discuss here. Right now, most common presentation of a testicular malignancy is painless testicular mass. So patient will come to you with painless testicular mass. What will be your next step? Next line of investigation. Your next line of investigation, very good, is clinical examination. And in this clinical examination, very important point, you are supposed to do fluctuation test and trans-elimination test. You should know this, that the most common cause of painless testicular mass is actually hydrocele. Most common cause of painless testicular mass is hydrocele. So you should first rule out hydrocele. So you will do a fluctuation and trans-elimination. You will do fluctuation and trans-elimination. Right? If the testicular mass is fluctuant and trans-eliminant, you know what is trans-elimination? So if you put a torch on the side of the testis, and if you can see that the testis getting illuminated, it is trans-elimination positive. So if the testis has fluctuation and the trans-elimination positive, it is considered as hydrocele and will be managed as hydrocele. Right? If it is non-fluctuant, if it is non-trans-eliminant, means a swelling will be non-trans-eliminant when it is solid. When the swelling is solid, any swelling when it is solid, it will not transmit light. Right? So in these situations, the next investigation you are going to do is ultrasound scrotum. If ultrasound scrotum says what you have seen on clinical examination, if ultrasound scrotum says that it's a solid mass, if ultrasound scrotum says that it's a solid mass, confirms your clinical finding without any further delay or any other FNAC or transscrotal biopsy, we will proceed to high inguinal orchidectomy. We will do orchidectomy directly. No transscrotal biopsy, no FNAC. Right? You will remove the testis from the inguinal canal. You can remove testis by giving incision on scrotum also, but you will not do that. You will remove the testis by giving incision on the inguinal canal and then removing it. Reason? The reason is the scrotum has a different lymphatic drainage and the testis has a different lymphatic drainage. Scrotum की lymphatic drainage जाती है inguinal canal. Testis की lymphatic drainage जाती है pre-paraiotic and inter-arteriocaval lymph node. तो अगर आप scrotum से approach करोगे, so you can spread the malignancy to scrotum and it will go to the another lymph channel and it will become a distant metastasis. So we don't want to do that. So we will do a inguinal orchidectomy. After that, we do a CT scan to stage this disease, and after staging, we don't need to go into the staging part. We just need to know after high inguinal orchidectomy, in most of the cases, we give chemotherapy. And the preferred chemotherapy is cisplatin and carboplatin based chemotherapy, which is called platinum based chemotherapy. So this is what a clinical approach is. Any doubt here? Right? Then comes another condition which is important for exam is phimosis. What is phimosis? Inability to retract foreskin of penis is phimosis. Now, important to note is phimosis can be physiological, phimosis can be pathological. Phimosis can be physiological, phimosis can be pathological also. Physiological phimosis is going to be there at birth. Physiological phimosis is going to be there at birth. So in these newborns at birth, you will find that you are not able to retract the foreskin of the penis. So in such newborns, we should not forcefully try to retract it. We don't need to do anything. We offer watchful waiting till 3 to 4 years of life. Because as the baby grows, this attachment of the foreskin with the glass gets released and it gets back to normal. But if after 3 to 4 years waiting, important is this. If the phimosis doesn't get relieved, physiological phimosis, we are left with no choice but to intervene now. And how will we intervene? We will intervene. The first line of management is corticosteroid cream, the local application. With a corticosteroid application, it may get relieved. If it fails to get relieved, you are supposed to do circumcision. You are supposed to do circumcision. सर्जन किसलिए आर्टरी फोर्सेप्स डाल के सेपरेट करके यूज किया, right now pathological phimosis, the most important predisposing factor, sorry, most important predisposing factor for pathological phimosis is poor hygiene. The other reason can be also belanoposthitis. Belanoposthitis means inflammation of glass or prepuce. Inflammation of glass or prepuce is called belanoposthitis. If there is an inflammation of glass or prepuce happens, then also the adhesion between the foreskin with the glass develops. So this leads to pathological phimosis. Now, in pathological phimosis, how will these patients are going to present to us? The most common presentation of these patients will be inability to retract foreskin, which was getting retracted earlier, no more getting retracted now. Patient can also come to us, important, with retention of urine because of this. Patient can also come to us with complaint of painful erection. Painful erection. Now, the treatment of choice for pathological phimosis is circumcision. Treatment of choice for pathological phimosis is circumcision, and you should know. So that means circumcision is done in various scenarios. One reason of circumcision is phimosis, pathological phimosis or physiological phimosis, which is not settling with a watchful waiting. Second reason for circumcision is it can be religious also. It can be religious also. And third reason of circumcision can also be cosmetic. There can be cosmetic reason for circumcision too. And there are advantages with circumcision also. What are the advantages with circumcision? It decreases the risk of STDs, sexually transmitted diseases, right? And circumcision, important to note, also decreases the risk of carcinoma penis. Important point. Circumcision also decreases the risk of carcinoma penis. But at what age, if you do circumcision, it decreases the risk of carcinoma penis? Checked again. Only at the neonatal age group. If it is done at this age group, then only circumcision will be protective for a carcinoma penis. Otherwise, at later age group, it is not going to be. Okay, and you don't need to go into further detail here in this. You just need to know the technique of doing a circumcision, just the name required, called plastibell technique. The technique of circumcision is called plastibell technique. So they can ask you, in which of the following condition you do a plastibell technique, right? So this is what we need to know about a phimosis and circumcision. Then, that is, there is no disadvantage. No disadvantage. There is no disadvantage. Circumcision has advantages, no disadvantage. So one can think of. Then comes Carcinoma penis. Carcinoma penis. Most common site, most common type. Most common site of carcinoma penis. Most common site, penis. Glans followed by prepuce. Most common site of carcinoma penis is glans followed by prepuce. Most common type is squamous cell carcinoma. Most common type is squamous cell carcinoma. And can you tell me what is the most important risk factor for carcinoma penis? Don't tell me male gender. What is the most important risk factor for carcinoma penis? Very good. The most important risk factor for carcinoma penis is phimosis. The other risk factors are human papilloma virus, 16, 18, 31 and 33 here also. More commonly 16, important. More commonly 16. Then also lichen sclerosis, which is also called balanitis, xerotica obliterans. Balanitis, xerotica obliterans, and also multiple sexual partners. There are certain pre-malignant lesions also which we should know for carcinoma penis. The pre-malignant lesions of carcinoma penis are erythroplasia of Currier, Bowen's disease, penile cutaneous horns, Buschke, Lowenstein tumor, and condyloma acuminatum. These are the pre-malignant lesions for carcinoma penis. Protective factor, female gender. Protective factor is neonatal circumcision. I was taking the class in one of the batch. After the discussion on carcinoma penis, I took a break. And when I came back, on my table, एक anonymous सा चिट पड़ा था, slip पड़ी थी. मैंने खोल के देखा, so I could make out the way it was, the question, the way it was asked, the question was asked. So I could make out the distress. The question was, sir, how many sexual partners? And I could make out the distress to the, the way it was framed. I was like कि ये तो कोई study नहीं है, कितने sexual partners, but अब anxiety तो दूर करनी थी. So I said that just before this discussion, we had a discussion on various malignancies, where we talked about red meat is a risk factor for colorectal cancer, high protein diet, high fatty diet is a risk factor for colorectal cancer, and various malignancies, like various risk factors are there. So are you going to stop consuming red meat or high fatty diet? So why bother? So, acuminatum. The most common presentation of carcinoma penis is painless penile ulcer. Patient can also come to us with inguinal lymph node enlargement. Patient can also come to us with inguinal lymph node enlargement. Why? Because the most common mode of spread of penile cancer is lymphatic. And the lymphatic of penile malignancy goes to inguinal group of lymph nodes. The lymph flow of the penis goes to inguinal group of lymph nodes. Investigation of choice is biopsy. Investigation of choice for staging is CT scan. Investigation of choice for staging is CT scan. Now, in management of penile cancer, we should know this. We have the option of surgery. We have the option of chemo. We have the option of radiotherapy. And we have the option of 5-fluorouracil cream also. Chemotherapy is offered when patient has distant metastasis. Radiotherapy and 5-fluorouracil cream is offered when the patient has in situ type of carcinoma. Radiotherapy can also be offered when patient wants to preserve penis. Patient wants to preserve penis, then also radiotherapy can be offered, but the primary modality of treatment is surgery. Primary modality of treatment is surgery. And in surgery, we are supposed to do wide excision with 2 centimeter margin. In surgery, we are supposed to do wide excision with 2 centimeter margin. With this wide excision with 2 centimeter margin, we may end up having a partial penectomy. We may end up having a total penectomy. Now, this understanding is important for you, which I am going to tell you. This, imagine, is penis. And imagine there is an ulcer here, right? Now, to decide whether the patient should have a partial penectomy as a procedure or a total penectomy as a procedure, this is very important for us to understand. हमें यहाँ से 2 सेंटीमीटर मार्जिन लेना, ठीक है? We have to take 2 centimeter margin. Now, after taking 2 centimeter margin, we have to see how much stump is remaining. We have to see how much stump of the penis is remaining. If the stump remaining is more than 2 centimeter or equal to 2 centimeter, we will do a partial penectomy. We will remove this part and we will leave this stump. This will be partial penectomy. But if the stump remaining of the penis after, imagine there is a growth here, and taking 2 centimeter margin, you are having a stump coming like this, which is less than 2 centimeter. Imagine. So if the stump after wide excision of 2 centimeter margin is coming to be less than 2 centimeter, we should rather do a total penectomy. We will not do partial penectomy. We will then do a total penectomy. To have a functionality of a penile stump, you need to have 2 centimeter. So if you are not getting it, you should go ahead with a total penectomy. This is what we need to know. And then one more thing we should know here. There is something called Mohs micrographic excision has come up. You should know what is this Mohs micrographic excision because it's the latest thing. Mohs micrographic excision, which has come up in penile malignancy. What we do in this? We make pathologists sit in the operating room. Obviously with a microscope. Otherwise, what will you do sitting there? So we'll make him sit in the operating room with a microscope. And we keep on chopping off penis 1 mm margin with 1 mm margin. And keep subjecting these margins for a microscopic examination. Till the time we get a negative margin. No malignant cell seen in the margin is negative margin. So moment we get that, we stop our dissection there. This is called Mohs micrographic excision. Its advantage kya hua? We could conserve or preserve a part of the penis. So this is called Mohs micrographic excision. Right? And this has come up in penile malignancy now. Another important point to note in penile malignancy, for a preputial penile malignancy, the wide excision with 2 centimeter margin is actually in that we do circumcision. So circumcision can be a treatment also for a preputial penile malignancy. Circumcision is going to be a treatment for a preputial penile malignancy. Important. Another important point, we know that the most common presentation of penile malignancy is painless ulcer. And you can appreciate that this ulcer, at the location it has, there are very high chances of this ulcer to get infected also, because it's a dirty area. So this ulcer may get infected too. So if this ulcer get infected, one can appreciate that the lymph node in the inguinal region can get enlarged. Because of infection also, the lymph node may get enlarged. Yes or no? Right? So in any patient of penile malignancy, before we consider the lymph node in the inguinal region enlarged due to metastasis, we should always give them an antibiotic therapy for 3 to 6 weeks. If after antibiotic therapy, important point here, if with antibiotic therapy the lymph node get resolved, it means these lymph nodes were due to the infection. If after antibiotic trial the lymph nodes are still there, it means this is a metastatic lymph node. So this is important in a penile malignancy, that whenever the lymph node in inguinal region is found to be enlarged in these patients, we have to first give the antibiotic therapy. And the most common cause of death in penile malignancy is bleeding. Is bleeding due to femoral artery blowout? A question asked. The most common cause of death in penile malignancy is bleeding due to femoral artery blowout. Okay, so these are the things we need to know in penile malignancy. Then comes normal. Then comes hypospadias. This hypospadias, important to note, is the most common congenital anomaly of hypospadias is the most common congenital anomaly of lower urinary tract. Hypospadias is the most common congenital anomaly of lower urinary tract. Now, in this condition, what happens is, this is a condition where there is a problem in the growth of urethra. Hypospadias is a condition where the urethra stops growing. What happens because when the urethra stops growing, I'll make you understand, but first write this down. In this condition, you will find ventral opening of the urethra. You will find ventral opening of urethra. You will find ventral chordae. What is this ventral chordae, ventral opening? We'll talk about. We will find dorsal hood. There is another condition called epispadias, which is not common though, but we should know about that too. There is hypospadias, which is common. Epispadias is not a common condition. What is epispadias and what is hypospadias? We need to know. In epispadias, there is a dorsal opening of penis, dorsal opening of urethra. There is dorsal chordae and there is ventral hood. अब ये condition है क्या? Let's understand this. This much only required in epispadias. No further thing required in epispadias because it's a very, very rare condition. You will just be checked on this, nothing else. In hypospadias, this is, imagine a penis. In this, urethra opens on the ventral side of the penis. Now, what is happening here is, देखो क्या है? Penis, I made you understand in our discussion on trauma also. Penis has 3 tubes: urethra, corpora cavernosa, corpora spongiosa, and there is a Buck's fascia. You know that. Urethra has a different embryological origin. Corpora cavernosa and spongiosa has a different embryological origin. Right? Whenever penis grows normally. All these structures, though they are from a different embryological origin, they grow in tandem. How they grow in tandem? They grow in tandem because they are attached to each other. So they have a together growth, right? So they are attached to each other. Now, in hypospadias problem, what happens is urethra stops growing after few millimeter or few centimeter growth. In this condition, the urethra stops growing. Now, once urethra stops growing, corpora cavernosa and spongosa is from a different embryological origin. They have no problem in the growth. They keep growing. So when they keep growing, what happens? Urethra has stopped growing and corpora cavernosa and spongosa kept growing. They are connected with each other. So since they are connected with each other, urethra pulls this corpora cavernosa and spongosa towards it because urethra stopped growing. So because of this, what happens is penis assumes a curvature, which is called chordae, right? So in both epispadias and hypospadias, the problem is in the growth of the urethra. In hypospadias, the urethra stops growing and opens on the ventral side of the penis. And once urethra opens on the ventral side of the penis assumes a curvature on the ventral side like this, which is called ventral chordae. Now, when corpora cavernosa and spongosa kept growing, they form a cap-like thing over the urethra. So this cap-like structure in hypospadias is on the dorsal side because the urethra is on the ventral side. So there are two ventral things in hypospadias, one dorsal thing. In epispadias, two dorsal thing and one ventral. So this is something we have to understand. Now there are various types of hypospadias. We have glandular hypospadias when the urethra opens at glans. When the urethra opens at glans, it is called glandular. And this is the most common type of hypospadias also. Glandular type of hypospadias is the most common type of hypospadias also. We have coronal type when urethra is opening at coronal sulcus. When the urethra is opening at coronal sulcus, it is called coronal. When urethra opens in penile shaft, it is called penile. When urethra opens at penoscrotal junction, it is called penoscrotal. And when urethra opens at perineum, it is called perineal. And this perineal is the least common type of hypospadias. And perineal is one type of hypospadias. Another important point to note, perineal is one type of hypospadias where determination of sex of the newborn will be difficult. And for determination of the sex of these newborns, we may need to do karyotyping. So there was a question asked, in which type of hypospadias karyotyping is required to determine sex? It is perineal type. Now, how do these patients are going to present to us? These patients are going to present to us. The most common presentation in them is urinary stream falling close to the body. Urinary stream falling close to the body. Patient can come to us with painful erection. Patient can come to us with impotence also. This is how these patients are going to come to us. Right? Now, in management of these patients of hypospadias, important, there is no urethra. So we have to reconstruct urethra. So, since we have to reconstruct urethra, This surgery is called substitution. Substitution because we have to replace urethra with something. So it is called substitution urethroplasty. This surgery is called substitution urethroplasty. And for substituting urethra with something else, what something else? We can substitute urethra with buccal mucosa. We can make urethra of buccal mucosa. We can make urethra of preputial skin also. And very important point to note in this further, since in hypospadias, we may need a preputial skin for reconstruction of urethra. In a patient of hypospadias, write down in capital letters, one should not do circumcision. In a patient of hypospadias, since preputial skin is required for reconstruction of urethra, circumcision should not be done. Got it? Now, in this surgery, you also need to know here, this surgery is done in steps. The first surgery you do will be a caudy correction. You have to first correct the curvature. Then only there is point of creating a new urethra. Then we will do a substitution urethroplasty, and after that we may need to do neatoplasty, and sometime we may need to do scrotoplasty also. Caudy correction is the first thing you are going to do. Then you will do a substitution urethroplasty. Then you should do neatoplasty, and then you should do scrotoplasty. Right? And the guideline says this caudy correction should start at the age of 6 to 10 months. So if you are asked what is the best time of doing correction for hypospadias, it is 6 to 10 months. And all these things should be over by 18 months. So best time of repair for hypospadias, if asked, it is 6 to 18 months. If not in the choice, then 6 to 10 months. And they can ask you what is the best season also. They have asked it. They can stoop down to any level. The best season is winter season. Not because it's a romantic season, because the healing is better. Two topics. One is bladder stone. There are two types of stones in bladder. There are two types of stones in bladder. Primary bladder stone and secondary bladder stone. Now this is something important. What is primary and what is secondary? Can you tell me?
Increasing in the bladder is primary.
जो कहीं से आया,
जो bladder में है वो
कहाँ से आ रहा है? So primary is formed in bladder, secondary is coming from kidney. यही ना? हाँ, तुम्हारा ही पूछ रहा हूँ. किसी और का कोई मतलब? It is other way round. Please remember this. This is something important. CBD stone में primary CBD stone is formed in CBD. Secondary CBD stone was coming from gallbladder. यहाँ उल्टा है. primary bladder stone is dropping down from kidney. Secondary bladder stones are formed in bladder. And please be very careful about this because there is a lot of confusion on this. Most common bladder stone in pediatric age group, if asked, please be very careful. It is endemic stone. What is endemic stone? What is endemic stone? I told you. बताया शायद मैंने ना? क्या था? Ammonium acid urate stone. Most common bladder stone in adults, if asked, or in general asked. Adult not mentioned, in general asked. Most common bladder stone in adult or most common bladder stone, if asked, it is phosphate stone followed by uric acid stone. Most common presentation of a patient of bladder stone is terminal hematuria. Earliest presentation of bladder stone, if asked, it is increased frequency of micturition. Earliest presentation of bladder stone, if asked, it is increased micturition, increased frequency of micturition. And if characteristic symptom asked, important, it is strangury. What is strangury? Huh? It's a very classical. Strangury is pulling of penis. Strangury is a characteristic thing here. Pulling of penis due to pain. Pulling of penis due to pain at the end of micturition is strangury. If somebody is coming to you with this complaint, it is classical of bladder stone. Pulling of penis due to pain at the end of micturition. Right? Now, in management of bladder stones, in management of a patient of bladder stones, we have shock wave lithotripsy. We have shock wave lithotripsy. We have transurethral litholapexy or lithotripsy. Transurethral litholapexy or lithotripsy. Percutaneous litholapexy or lithotripsy. And we also have open cystolithotomy. Open cystolithotomy. Preferred is transurethral litholapexy or lithotripsy. One more thing we just need to know here. In this litholapexy or lithotripsy, we can use, just note this, electrohydraulic lithotripter we can also use laser. Laser used here is holmium laser. This is important. In this litholapexy or lithotripsy, we can use electrohydraulic lithotripter. We can use laser also. The laser used here is holmium laser. And the commonly used is electrohydraulic lithotripter. Commonly out of the two we use is electrohydraulic lithotripter. Now the last thing is carcinoma, urinary bladder. Most common site, most common type. Most common site of carcinoma bladder is posterior, superior part of trigone of bladder. Posterior, superior part of trigone of bladder. Most common type is transitional cell carcinoma. In risk factors, we should know the most important risk factor is smoking. After smoking, important. The second important risk factor is dyes. Which dye? Aniline and benzidine dyes. Stones के लिए नहीं. Transitional cell. And because there is a dye is a risk factor for bladder cancer, it is considered under occupational hazards. What all occupations have risk of bladder malignancy, we should know that too. Workers working in tire industry, workers working in tire industries, leather industry workers, rubber industry workers, painters also. They have a risk of bladder malignancy. Then, important to note, schistosomia hematobium. Schistosomia hematobium is also a risk factor for bladder cancer. But please highlight that in your notes. It is more important a risk factor for squamous cell carcinoma of the bladder. Schistosomia hematobium. Schistosoma hematobium is a risk factor for transitional cell also and squamous also, but more importantly, it is a risk factor for squamous cell. More importantly, it's a risk factor for squamous cell. And cyclophosphamide is also a risk factor for bladder cancer. Transitional cell type, important. Most common and characteristic presentation of a bladder malignancy. Most common and characteristic, I already told you, is painless, terminal, hematuria. Strangulary is for bladder stone. What will be the next step if the patient comes to you with this? After clinical examination, investigation of choice, cystoscopy. Investigation of choice is cystoscopy. Investigation of choice for staging is MRI. Now, I am again going to give you a very simple way of understanding the management of carcinoma bladder. If you understand this, you can answer any question on management of carcinoma bladder. What is that? You already know that in hollow organs, T stands for depth of penetration. T stands for depth of penetration. So just let me know if T2 is a muscle invasion. Just remember this. Just remember this. If T2 is muscle invasion, submucosal invasion, mucosal invasion of the bladder wall will come in T3 or T1. सिंपल सी बात है. मसल में चला गया तो T2 है, उससे पहले होगा तो T1 होगा. तो हमें सिर्फ T2 याद रखना. हमें सिर्फ T2 याद रखना. सिर्फ T2 याद करने से हमारा सारा काम हो जाएगा. कैसे? अगर in your given question you are told the tumor is T2 or beyond, T2 or beyond, or you are told that the lymph node is enlarged, any T, कोई भी T हो, एक बार lymph node enlarged बोल दिया. In this specific type of patients, your answer is going to be neoadjuvant chemotherapy followed by radical cystectomy, means removal of the urinary bladder, followed by chemo. बाकी सारे पेशेंट्स का आंसर होगा TURBT followed by intravesical BCG, the BCG vaccine which you give for tuberculosis. TURBT is transurethral resection of bladder tumor. Transurethral resection of bladder tumor. ओके, बाकी सारे क्वेश्चंस का आंसर ये, सिर्फ इन को छोड़ दो. समझ आ रही है बात? ये वर्किंग फॉर्मूला है एंड it makes life very simple for us, otherwise it is very difficult to remember things. Ab radical cystectomy means removal of the urinary bladder with lymph nodes. Removal of the urinary bladder with lymph nodes, you can understand with the name. So when you remove urinary bladder, how will the urine be drained? So we need a urinary diversion. We need a urinary diversion. Obviously, आपने ब्लैडर निकाल दिया तो आपको यूरिनरी डाइवर्जन के लिए कोई तो तरीका चाहिए होगा. The urinary diversion हम पहले जो कर रहे थे, the urinary diversion we were doing earlier, which we don't do anymore though, was ureterosigmoidostomy. क्या मतलब हुआ इसका? ये सिग्मॉइड कोलोन है, हमने यूरेटर को सिग्मॉइड कोलोन के साथ जोड़ दिया। क्या सूचर मटेरियल यूज करेंगे? वही तो कंफ्यूजन दूर करने के लिए पूछ रहा हूँ। तो मास्क के पीछे कुछ भी बोल दे। क्या 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 सोच रहे? पीडीएस यूरेटर में स्टोन बनते हैं? नहीं बनते। किडनी से स्टोन आके यूरेटर में आके स्टोन बन सकता है। अगर यूरेटर में स्टेसिस हो जाएगा, यूरेटर में कोई फॉरेन बॉडी अगर आ जाएगी तो क्या स्टोन बन जाएगा? यूरेटर में स्टोन होते हैं कि नहीं होते हैं? सिंपल सी बात है, होते हैं, सी बात होते हैं। तो जहां पे स्टोन होते हैं वहां पे क्या हम पीडीएस यूज करते हैं? और प्रोलीन कहां से आया? प्रोलीन तो हम कभी करते ही नहीं इंटेस्टाइन में। तो वही तो, यही सोचना है, जल्दी से आंसर नहीं करना है, सोचना है। अगर हम इंटेस्टाइन में कुछ कर रहे हैं तो हमें पीडीएस यूज करना है। अगर हमें कहीं स्ट्रेंथ चाहिए तो हमें प्रोलीन यूज करना है। अगर जहां पे स्टोन बनते हैं वहां पे वाइक्री यूज करना है। सिंपल। स्ट्रेंथ जैसे कोई टेंडन को रिपेयर कर रहे हो, एक्सटर्नल ओब्लिक एपोनेरोसिस को रिपेयर कर रहे हो, फेशियल आर्टा को रिपेयर कर रहे हो, जो बॉडी को स्ट्रेंथ देंगी। ट्रॉमा में नहीं, जो टिश्यू जिन दो टिश्यू को आप जोड़ रहे हो, वो टिश्यू अगर आपको स्ट्रेंथ देने वाले बॉडी को, वहां प्रोलीन यूज करो। या फिर आप वेसल रिपेयर कर रहे हो। वेसल एक ऐसी जगह है जहां पे स्ट्रेंथ नहीं है बट फिर भी हम प्रोलीन यूज करते हैं, मैंने बताया था। ठीक है। सो अर्लियर वी वर डूइंग अ यूरेट्रोसिग्मॉइडोस्टमी फॉर दिस यूरिनरी डाइवर्जन। वी स्टॉप्ड डूइंग इट। व्हाई? बिकॉज इट लेड टू सीवियर hyperchloremic metabolic acidosis. अब हम क्या करते हैं? The urinary diversion of choice is ileal conduit. Urinary diversion of choice now is ileal conduit, and the most common complication of this is uretro-ileal stricture. The urinary diversion of choice now after removing bladder is ileal conduit. अब ये ileal conduit का क्या मतलब हुआ? हम क्या करते हैं? The most common complication of it is uretro-ileal stricture. क्या करते हैं इसमें? हम एक इंटेस्टाइन को नॉर्मल बावल से इंटेस्टाइन को सेपरेट करते हैं। नॉर्मल बावल की कंटिन्यूटी से इंटेस्टाइन को निकाल लेते हैं, पार्ट ऑफ द इंटेस्टाइन को निकाल लेते हैं। छोटा सा पार्ट एक इंटेस्टाइन का हम बाहर निकाल लेते हैं उसकी मिजेंट्री के साथ। ठीक है। अब इसका जो ये प्रॉक्सिमल एंड है, मान लो ये प्रॉक्सिमल एंड है और ये डिस्टल एंड है। इस प्रॉक्सिमल एंड को हम बंद कर देते हैं, डिस्टल एंड को एब्डोमिनल वॉल में बाहर निकाल देते हैं। अगर हम आइलियम को एब्डोमिनल वॉल पे ओपन कर देंगे तो उसको क्या बोलेंगे? आइलियोस्टमी। सो हम आइलियोस्टमी बना देते हैं। अब इस आइलियम को जिसको हमने निकाला बाहर, एक सेगमेंट को, इसके साथ हम यूरेटर को एनास्मोज कर देते हैं। अब जो है यूरिन यहाँ पे कलेक्टिंग बैग है, उसमें कलेक्ट होता रहेगा। दिस इज कॉल्ड आइलियल कॉन्ड्यूट and this is the urinary diversion of choice after removal of bladder. And this is all about our discussion on surgery. This is my sincere request to you. surgery is, I understand, I know, is a vast subject, but सर्जरी छोड़ के मत जाना। सर्जरी जो ये टॉपिक्स मैंने बोले, अगर ऐसा लग रहा है कि आपको के पास टाइम नहीं बच रहा और आपके पास कोई ऑप्शन नहीं है, तब एटलीस्ट ये टॉपिक तो देखना ही है। और जो हम टेस्ट एंड डिस्कशन करेंगे वो प्लीज अटेंड करना, क्योंकि उसमें इमेजेस होंगे और उसमें मैं कई चीजें और दिमाग में उस समय कोशिश करूंगा कि अच्छे से जो इंपॉर्टेंट चीजें वो तब चली जाए और वो लास्ट मिनट में तुम लोग उसको वॉमिट भी कर दो, राइट। और एमसीक्यूज प्लीज करने, एमसीक्यूज के बिना क्वेश्चंस वहां पे एग्जाम में सीधा सॉल्व होना में दिक्कत आएगी, तो एमसीक्यूज प्लीज कीप डूइंग इट। एंड यहाँ पे ये एग्जाम क्लियर होगा यहाँ से। इफ यू गिव अप, you will give up ever. So it is all about your mindset. If you decide that you have to clear this exam this time, you will clear it. आपको सिर्फ 150 नंबर चाहिए, आपको टॉप नहीं करना है, आपको 200 नहीं लाने, आपको सिर्फ 150 लाने हैं। 150 वाला भी पास है, 240 वाला भी पास होगा, सब एक लेवल है। तो हमें अभी टॉप करने का नहीं सोचना है, बस हमें ये सोचना है कि हमें पास इसी बार होगा। ये माइंडसेट से अगर पढ़ाई करोगे तो ऐसा पॉसिबल ही नहीं है। जितना टाइम अभी बचा हुआ है ना, इस टाइम में आराम से हो सकता है और अच्छे से हो सकता है और 200 से ऊपर नंबर वाला सीन हो सकता है। तो इसलिए प्लीज डोंट गिव अप इन योर माइंड, इट इज ऑल अबाउट हियर। सो लग रहा होगा कि वास्ट है चीजें, बट एक बार जब रिवाइज करोगे तो सब दिमाग में चलता जाएगा। ठीक है, ऑल द बेस्ट।